Great, good morning. Thank you to Holly and to Melissa for setting the groundwork when it comes to the sort of legal landscape and policy landscape for these research issues. I'm going to talk a little bit about the challenges that the way that the current common rule and more, I'm going to focus more on HIPAA, pose to those who are hoping to contribute to the learning healthcare system, a term that you all, I'm sure, understand. Lots of people ask me to define it, and then there's a sort of blank silence. But that there are some current challenges in the way that data is treated under the law that we think disincentivize the sharing of data to meet all of our shared public health goals. As we've heard, HIPAA allows the sharing of data for several categories without consent. The big ones that we think of are treatment and payment. When your healthcare data is used by providers or other covered entities for those purposes, there's no individual authorization or consent needed. And the rationale behind that is because they are expected uses of health data. We expect that when we go to the doctor, that's what they're going to be doing with our data. We hope that's what they do with our data. And as a result, there doesn't need to be this extra layer of protection, that being consent. And the third big category of uses of data for which authorization is not required are so-called healthcare operations. But for our purposes, we understand those to be more quality improvement purposes, and that is subsumed under the definition under HIPAA of healthcare operations. On the other hand, research uses of protected health information do require authorization because, again, the rationale is that that's not a necessarily expected use of one's health data, and as a result, there needs to be an extra layer of information and consent, information to the patient and consent for use of data for research purposes. And the common rule, as we've heard, is also likely to apply to many uses of data for research purposes. I won't read this definition. It's very long under HIPAA of healthcare operations, but the big piece of this definition that is problematic is that if the obtaining of the data and the use of the data is the primary purpose of which is not to contribute to generalizable knowledge, then you're in the clear. You're in the healthcare operations category and consent is not needed or authorization is not needed. As you see, the definition of research, however, is specifically designed to contribute to generalizable knowledge. So very often when you're using data for a purpose and you're trying to figure out whether or not it's going to be qualified as healthcare operations or research purposes, you have to make a determination of whether or not you're trying to contribute to generalizable knowledge. This is similar under the common rule because the definition of research is almost identical. And so it really creates a paradox. You can have two studies using data for quality improvement purposes. You think that that's what your intent is, and they use the same data points, they're done to address the same research question or set of questions, and they're done by the same institution. But if you want to share those results, if you want to help the world, contribute to generalizable knowledge, publish them, share them at all, they're going to be treated as research. If you keep them internal, they're going to be treated as healthcare operations. Again, this is treatment under the law, and the big important distinction under the law is whether or not you need to obtain patient authorization. So it creates a real roadblock to the learning healthcare system because you have these sort of disincentives. On the other hand, there's no discernible increased protection to a patient or to a human subject by setting up this distinction. We heard a lot about the ANPRM to the common rule, and I just want to point out that the Health IT Policy Committee, which is one of the federal advisory boards set up by the HITECH Act, developed and submitted a lengthy set of comments to this ANPRM in which CDT, my organization, was very involved. And one of the big thrusts of the comment letter was to please align these rules better so that even if the intent is to share results of a study or an internal work for generalizable knowledge, it can't be treated automatically as research. Of course, there should be appropriate oversight and control mechanisms for this. It shouldn't be a complete pass. But really, this hopefully, in terms of this alignment, we can eliminate or at least mitigate this big distinction. The letter also asked that the agency follow the full complement of fair information practices as it develops frameworks for use of PHI, and I'll talk a little bit more about what the fair information practice principles are. And then the letter went on to provide some recommendations based on, here's some examples of activities that might pose more risk and therefore deserve more protections, and here are some that are more routine and then therefore might pose less. And in tiny print is the link to that, but you can find it on the HHS website. So as I mentioned, this paradox is created by the differential treatment of data when used for quality improvement research purposes. And in addition, the current structure puts too much focus on a couple of privacy tools. That's not to say that they're not important, but they're not the only ways to protect data. The sort of big dividing line is de-identified data versus identifiable data, and that's certainly important, but it's not the only thing that makes data more risky. Data use is identifiability, and even though de-identification is certainly important and there should be incentives to use less identifiable data, it's not infallible. It's not the be-all and end-all. And I would say the same about consent. It's certainly important to have consent mechanisms in place, but I think that we tend to talk too much about, we get too much down a consent rabbit hole when we're talking about privacy protections, and endless discussions over whether opt-in or opt-out is better, and what means and what is meant by informed consent. But it's just one component, and authorizations tend to either be so general and therefore sort of useful to the patient because they're short and understandable, but then they don't provide that meaningful protections, or they're incredibly meaningful because they explain absolutely everything, and then you get the 22-page, 10-point font authorization form that gets put immediately in the trash after it's signed, or just signed because it's too long without being read. So it's not, in practice, a particularly meaningful way of involving patients in control of their data, or feeling sort of meaningfully involved in what's happening to their data. So again, these are two of the fair information practice principles that are sort of, all of the focus is on them, but a lot of the others are ignored. My colleague Devin McGraw and I have done a lot of work in the last year with multi-site research initiatives, talking with them about what is it in the current HIPAA and Common Rule structure and landscape that is making it hard for you to do the work that you want to do. And it's really directly related to most of what I've just talked about. They want to publish results, they want to share results, they want to contribute to generalizable knowledge. But in many cases, they're scared to do so because the barriers to research are often insurmountable, especially for smaller or less experienced institutions. And also, they're not sure what it is that they're doing. They're doing a study, and they're not quite sure whether or not they're going to fall into the research category or the healthcare operations category, because the law and the regulations really are in many ways ambiguous, unless you're nerdy like all of the people on our panel and understand it at least somewhat. So, of course, understandably, it tends to lead to a better safe than sorry approach. You start doing a study and you just think to yourself, well, I'm going to clearly treat this as if it were research. I'm going to go through the whole IRB mechanism, because you don't want to get to the end point and realize that you're going to be treated as research and not have gone through the IRB or not have obtained authorization. And the retroactive jumping through hoops can be unbelievably time-consuming and expensive. This is a tiny bit of a tangent, but another thing that these initiatives said is that they wish that there was some incentive under the law to have their networks, research networks, structured as we call federated or decentralized. The sort of other big way of doing research is in a centralized network, and the distinction that I make is it's either bringing the data to the analysis or bringing the analysis to the data. And from a privacy protection standpoint, a federated, a decentralized network is much safer, because you keep the data within the walls of the institution, however many institutions are involved in the study, and you do your work and you bring the analytic tools or set of criteria to the individual institution and then pool the analytic de-identified aggregate results, rather than moving all of the data physically to a big centralized warehouse and then running the analytics on that data. It's just one less layer of exposure. And given that that is a real way to keep data static, at least from a sort of physical privacy protective standpoint, it would make sense that as we think about ways to calibrate risk and degree of protections, that we provide some way to incentivize keeping the data where it is to the greatest extent possible. So I'm sure many of you are familiar with the Fair Information Practice Principles, and there are many different iterations of them, not just in the healthcare context. The one that we tend to rely on is the Markle Common Frameworks iteration of them, and this is largely what they look like in a healthcare context. And I won't read them out loud to you, but as you see, the individual participation and control is just one element of this, and that's what we tend to think of as consent. And so there are lots of other ways to layer on protection and lots of different tools to employ, and they too often get ignored in policy and legal discussions about data protection. The accountability and oversight is a big one that I don't think put enough attention on, the openness and transparency. And then a big deal is purpose, specification, and limitation, and we heard a little bit about that and how HIPAA has been rewritten to take account of that. But if this full complement of these practices is employed in rethinking the regulatory and legal structure for data, I think we're going to have a more fair and a more comprehensive approach to data protection. We've been doing some work at CDT and with other colleagues about thinking through a more risk-based framework. As I said in the beginning, HIPAA thinks of itself as being a risk-based framework. It's why for healthcare operations and data use that's kept internal, consent is not required, where if it's shared externally through research, it is, because again, it plays into what are individual expectations when you go to a doctor's office or enter a clinical setting, what's going to happen to your data. But we would posit that the mere publication of study results is not inherently more risky than not publishing it. And so there are a number of examples that we've been thinking through and trying to work through to think, what does a better risk-based framework look like? What makes data use risky? What types of data are more risky, and what is it that you do with them that exposes them to more risk? What are privacy harms? And how can we rethink the laws, at the very least amend them, but we like to think of just in a perfect world, if we were going to rewrite everything, what would it look like? Again, I've said this a number of times, but there should be less of a reliance on consent. Especially if there are uses that, especially in these days in our learning healthcare environment, really are routine. And then think of other models of patient engagement so that this individual participation and control element can be met, but not just through consent. Lots of talk about patient engagement in research, more transparency to the patient with regard to what are the research uses being contemplated now and in the future. And maybe some sort of requirement to involve patients throughout the study and then share results with patients directly. The last bullet point also that increasingly data is being supplied by patients themselves in this learning healthcare environment. So that's just another mechanism of patient engagement, which might make the inherent risk and the potential for violation of expectations to be much lower. And then there are a number of models out there of different ways of having accountability and oversight into data use and research purposes. We do a lot of work with governance entities and governance models. So again, that's another one of the fair information practice principles that we think could be put to better use. And finally, there needs to be some explicit studies done of the efficacy of whatever we're testing out in building patient trust. That this is the underlying principle of all of this, is patient trust. And so if we're trying all these things and then there's no measurement, it's going to be very hard to determine whether or not we're making any progress or just putting into place another system that's imperfect in ways that are potentially detrimental to our end goal. I think that's it. I look forward to questions.